Hello, I'm Laura. I'm one of the diabetes midwives, and I am here today to talk to you about gestational diabetes, about your pathway of care now and what will happen after your diagnosis. So as well as myself, there are additional gestational diabetes midwives. You will also be seen by consultants that specialises in gestational diabetes. You will also be seen by dietitians, dietetic assistants that will help you with your journey of gestational diabetes. So we are here today because you've all been diagnosed with gestational diabetes. And first of all, I just want to say that it is nothing that you have done or you are doing. Gestational diabetes is caused by your pregnancy hormones, and how it happens is that the pregnancy hormones, they make your cells insulin resistant. So instead of your glucose that's in your blood being used by your muscles or stored, that extra glucose, it crosses the placenta to help put weight on the baby. When that is happening, your pancreas then needs to increase its supply of insulin, and I'm certainly not saying that there's anything wrong with your pancreas, because there isn't. It just cannot keep up with that extra demand that's required in pregnancy. As a result of that, you do develop gestational diabetes. Gestational diabetes, it is just pregnancy related, and it generally goes away once you've had the baby. It might be that you attended your booking appointment with your community midwife and you were identified as having risk factors such as a raised BMI over 30. It could be down to your ethnicity. It could be down to whether you've got a family history of diabetes, and that would be your parents, your siblings of type 1 or type 2 diabetes. We do not screen if there's a family history of gestational diabetes. It could also be that you've got a condition called polycystic ovary syndrome, and like I say, if they were identified at booking, you would have been referred in there and then for a glucose tolerance test. It could also be that you developed symptoms during your pregnancy, and it could be that maybe you've attended a clinic appointment or an appointment with your midwife and you've had glucose in your urine. It could be that you've become extremely thirsty. It could be that you're also passing urine more frequently. It could also be that you've attended a scan and it has been identified that there's extra fluid around the baby called polyhydramnios, or it could be that little one's abdominal circumference is measuring large, and that would be classed over the 97th centile, or it could be that the estimated fetal weight is also plotting on your graph over the 97th centile. Again, we would offer you a glucose tolerance test or home monitoring dependent on your gestation. Having the diagnosis of gestational diabetes, it can cause additional complications. The main one that we do generally see is if your baby is measuring large for dates. This would be discussed with you at your clinic appointment, and this does increase your risk of shoulder dystocia. Again, this will be discussed by the consultant. This will not be discussed at depth in this presentation. Polyhydramnios, as mentioned earlier, is extra fluid around the baby. So one of the symptoms of diabetes is passing urine more frequently. So this is what's happening to your baby if they're exposed to extra or more sugar. They will be passing urine more frequently, which could increase the fluid that surrounds them. It can also affect the function of the placenta, so not only do we see larger babies, but we do see babies that maybe do not put on enough weight, or they're static in their growth, so they're not putting on any weight at all. If this is identified with one of the scans, you will then have more regular scans, and all of this will be discussed with you at your antenatal clinic appointments with the consultants. Gestational diabetes, it does come with an increased risk of stillbirth. This is more once you are over your due date. So all we would recommend, as we would anyone else, if you've got any concerns with reduced movements, then please do contact Pregnancy Assessment, and the telephone number will be on your badger notes. It might be the case that you are offered an earlier induction or a section, and these will also be discussed at your clinic appointments. Babies, if they are exposed to higher glucose levels, they are currently producing insulin to deal with that. Once they are delivered, we do not expect them to consume the amount of glucose that they are receiving at the moment, but because they will still be producing that amount of insulin, it does increase their risk of having hypoglycemia, which is low blood sugars. Because a baby cannot also regulate their own body temperature for the first 24 hours, if they are cold, they are going to be burning that glucose to try and keep warm. So again, that increases their risk of having low blood sugars. So what we would recommend is early feeds, regular feeds, and keeping the baby dry and warm to sort of like help with their body temperature. Having the diagnosis of gestational diabetes, it does increase your risk of type 2 diabetes, and that risk has gone up by 60%. It is a lifelong risk, and we do recommend that you have annual screening so that your GP can just monitor and make sure that there is no signs of type 2 diabetes. If anybody goes on to have future pregnancies, again, you are at the increased risk of gestational diabetes, and that risk has gone up by 80%. And because of that, we would offer you earlier screening around about 16 weeks. So what happens after your diagnosis is that you will have weekly contacts with either myself or one of the other diabetic midwives. During these weekly contacts, we will review your readings. We will let you know as to whether we're happy for you to continue as diet controlled or whether we think you need to start treatment. Following this appointment, we will then schedule another appointment for the following week, but you do have our contact details, you have our generic email, our work emails, as well as the office and our work mobile numbers, so please do get in touch if you have any concerns. We have been in contact with the antenatal clinic, so we have arranged for you to have scans and clinic appointments around 28, 32 and 36 weeks, and scans will follow with that as well. It might be the case that we cannot get you scans and clinic appointments on the same day, so you might have a scan one day and then you'll have a telephone appointment, or you will be in clinic for both face-to-face appointments. For the ones of you that do live around Hexham, Berwick or Alnwick, we will keep your scans there, and then you will more than likely just be added to the diabetes clinic appointments. But if you do feel that you want a face-to-face appointment instead of a telephone, then please do let us know, we can arrange that. You do continue to see your community midwife as normal because she is your routine appointments. We are extra, okay? We can help you with your common pregnancy symptoms if you've got any concerns, but please do continue to see your community midwife. We do recommend that certainly anybody from 36 weeks to start colostrum harvesting, especially if you have got diabetes. And that just means that you've got the colostrum there in your syringes if you've got a little one that is a bit reluctant to feed. Your community midwife will discuss that with you, but again, when you see us in clinic, we will discuss that with you as well. We've got packs, so we can hand you out the packs as well as your community midwife. As said earlier, anything urgent, such as reduced movements, if you think you're in labour, if you think your waters have gone, any pain, any bleeding, please contact Pregnancy Assessment Unit. Monitoring your blood sugars, you need to be monitoring 4 times a day, so please ignore any information where it says that you need to be monitoring 6 or more. It is just 4. The first time of the day is in the morning when you wake up before you have anything to eat and drink. That is your fasting level. The other 3 times will be 1 hour after your breakfast, 1 hour after your lunch, and 1 hour after your evening meal. You do not need to do before meals, you do not need to do before or after snacks, and you certainly do not need to do before bed or during the night. So it is just 4 times a day. Your fasting target needs to be below 5.3, so if you are getting 5.3 and above, that is a raised fasting level. Your 1 hour post-meal reading needs to be below 7.8, so if you are getting 7.8 and above, again, that is a raised reading. We totally appreciate that you might struggle to get the 1 hour reading at times, so you do have scope to go to 2 hours, and that reading needs to be below 6.4, so a reading of 6.4 and above is raised. We have been in contact with your GP to let them know that you have been diagnosed with gestational diabetes, and they will be the ones that will give you prescriptions for additional test strips, needles and a sharps box. Please do give them at least 3 days notice if you are running low on your equipment, and we do not keep any spare stock with us, so it will be your GP. Your sharps box, if it's full, please take it to your chosen pharmacy. Please do not return it to us because we cannot dispose of it. It will be your pharmacy. The same as when you've delivered, if you are on treatment, please return that to your pharmacy as well. We do start everybody off on diet control, and this is where you will have the contact with one of the dietitians, whether it's the dietitian herself or whether it's a dietetic assistant. Diet controlled is you focusing on your carbohydrates, because it's your carbohydrates that will spike your levels, whether it's sugary or starchy carbs. Now, we are not here to tell you that you cannot eat carbs, because that is your source of energy and you need that as part of a healthy, balanced diet. If you do get to the point where you're struggling, you feel that you've made all your changes or you've cut out your carbohydrates, please let us know, because we can discuss treatment with you. Another good thing to add into your daily routine is physical activity, because your muscles will burn that glucose. So certainly if you've had a meal, you think it's going to cause a spike with your levels, add even something like a 30-minute walk will hopefully be enough to just help bring your levels down. If we get to the point, we certainly like to give you 1 to 2 weeks. If we get to the point where we've reached that, you're still having raised levels, we will discuss treatment with you. Our first line of treatment is a tablet called metformin, and you will be started off on 1 tablet, so that would either be with your breakfast or with your evening meal. We may find that we need to build you up to the maximum dose, which is 2 tablets with breakfast or 2 tablets with evening meal. It might be the case that you just stay on 1 tablet. If we've reached the maximum dose, it will be then that we will discuss insulin with you. Please do not think that you've failed because you've ended up on treatment. We have a high proportion of our ladies on treatment, and that is mainly the metformin. We only have probably about 10% of our caseload that do need insulin. So as I've said, please do not think you've failed. Gestational diabetes is caused by your pregnancy hormones, and it's your pregnancy hormones that controls it. And certainly between 32 to 36 weeks, this is when it is more difficult to manage. So please do not blame yourself. You are battling with your pregnancy hormones. Delivery plans are usually made around about 36 weeks, and these will be made at your clinic appointment with your consultant. We're not here to force you down any route, so if you don't want to be offered an early induction, or you want a section versus a vaginal delivery, please let us know. We will support you, but we will start talking about this at your 36-week appointment. So once you've delivered, you'll be pleased to know that we treat you as if gestational diabetes has gone, so all of your monitoring stops. If you are on treatment, that stops as well. We recommend that you go for a blood test called an HbA1c with your GP around about 12-13 weeks. This is the same blood test that we would recommend you have every year, so that the doctors can just keep an eye that there's no signs of type 2 diabetes. Not all GP surgeries do make that recall for the appointment, so it might be worthwhile you picking a date and sticking to that and having that done sort of like around that same time every year. Regarding baby, we certainly recommend feeding within the first hour, ideally within the first 30 minutes. And then for 3 hourly feeds for the first 24 hours. We will be monitoring their blood sugars before the second and the third feed. So if your little one is showing signs of feeding, please buzz for the staff. They will know that they need to come and do the test. We like little ones' blood sugars to be 2 or above. If it is below 2, then you know, they'll contact special care, they'll get a plan in place, they'll check that baby's feeding okay, check the temperature. If it is really low, then it would be the case that maybe little one will need to go to special care for some glucose. If little one has passed the 2 readings, so they've got 2 or more, then we don't need to do it anymore. If everything is okay with you and baby following delivery, you do not need to stay in hospital any longer because of gestational diabetes, so that's probably a relief for some of you. If you have any additional questions or concerns following this presentation, then please do get in touch. Thank you for watching.